Good afternoon, everyone. My name is Zahara Namali. We are pleased to have all of you that have already logged on to this session. It is the Makerere University Lung Institute Day of Lung Science virtual session. We have quite a terrific panel. I'm just trying to cross-check and see if we have all our presenters logged on yet. But yes, I see Professor Bruce is already on. Waiting for Dr. Mbabazi, Dr. Nixon Niyonzima from the Uganda Cancer Institute, and Dr. Okuku, a consultant oncologist from the Uganda Cancer Institute, and the Executive Director, Uganda Cancer Institute, Dr. Jackson Orem, who will be joining us today to continue to emphasize the aspects of early detection of lung cancer as a key to reducing the cancer disease burden in Uganda. Our first presenter is supposed to be Dr. Okuku, who I don't know if he's already on. Dr. Okuku, are you online? Unfortunately, I think he has not logged on yet. Dr. Bruce, I don't know, can we start with you? Let's keep this rolling immediately to be able to save on time as we wait for Dr. Mbabazi, Dr. Okuku, Dr. Jackson, and Dr. Niyonzima to come on board for this session.
Okay, thank you, Zahara. I think, yes, we can start by the time we are done with this presentation. I think we will have other presenters log on. I want to thank everyone who has joined today's presentation on early detection of lung cancer. I will try to see if I can show my video so you don't get so bored in these lectures. So good afternoon, everyone. I think we'll start. This is our program today. I will double as the chair as well, but I'm also going to introduce the subject. I think Zahara is here to welcome you and to guide you on how you should register for the CPD. And then I will talk to you about the role of clinical evaluation in early cancer detection. And then I will have a presentation on radiological screening, which is actually the key in early detection. Then we'll have a session on biomarkers of lung cancer. As you know, this is quite important as access to radiology is not very easy in our setting. And then we will see how the Uganda Cancer Institute has strengthened the health system to be able to detect cancer early, and that will be given by Jackson and Nixon. So without more, I will go to my session. My session is about the role of clinical evaluation in early lung cancer detection. And the outline of this presentation, I will take you through the basics of lung cancer. I know this session is attended by both medical and non-medical people. So I will try as much as possible to cover both audience. And then I will look at how you can suspect you have lung cancer yourself at home and how your doctor could suspect that you have lung cancer. And then I will go through our experience screening lung cancer for the last 3 years and what we have learned before. Zara, I hope people can hear me from that end.
Yes, Prof, you're loud and clear.
Okay, so we'll start with the basics. The basics of lung cancer. Lung cancer basically is cancer that originates from lung tissues, primary lung tissues. And the lung tissues, we have the parenchyma, the interstitium, the vessels, lymphatics and airways, but mainly we are talking about the main structure of the lung, and that's the lung parenchyma and its tissues. So lung cancer happens when normal cells in the lung change into abnormal cells and grow out of control, which is really the basics of all cancers. So when you talk about classification of lung cancer, many times people get confused about this. So today I want to make it, to see if I can make it memorable. So basically, you can talk about 4 or 5 major types of lung cancer. When we start by saying there are 2 main types, we say there are those ones which are small cell, and basically this is about 10% or 10 to 15% of all the lung cancer, and this is a reflection of how the cells, the size of the cells under the microscope. And then we have the non-small cell, which is 85 to 90%. As you can see, this classification is really very simplistic. This one is small, this one is not small. This is like saying this person is big, the other one is not big. But this has implication on how these cancers progress and how they present and their response to treatment. Now, the one which is non-small cell is subdivided into 4 major components, or 3 major components. That is adenocarcinoma, squamous cell, and large cell. And in this pie chart here, you can see that when you look at, so you can actually end up with about 4 major types of lung cancer, something to memorize. So start by saying non-small cell, then adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. So mainly 4 subtypes, but there are a few others. And you can see adenocarcinoma is about 40%, squamous cell is about 30%, large cell is about 10%, and small cell is about 15%. I am going to show you data from our histological typing of lung cancer, and we see how these same things have played out. And please remind me to come back to this pie chart. Now, if we look at that, you can actually complicate life a little bit, but I will not bother about this. This non-small cell, which we have seen accounts for up to 90% of all lung cancers, is divided into these subtypes, and I've shown you how they play out. Most of it is adenocarcinoma, then squamous cell, large cell, and others. And you can do molecular subtyping of these 2. And you can see for adenocarcinoma, which is ADC, you can have all these subtypes, these mutations, driving this kind of cancer. And the percentages are shown there. And then for squamous cell, the SQCC, these are the major driver mutations. This has implication for treatment, but today we are not going to discuss treatment. We are only discussing early detection. So, but one thing which I would want to encourage the audience, do not bother about this. This is part B. Part A is here. Now, if we go down, we want to look at the epidemiology of lung cancer. Who gets lung cancer and why do they get lung cancer? You can see in the year 2020, there were about 2.2 million lung cancer patients globally, and 1.8 million died. If you do a quick calculation, that's a very high mortality rate. Can someone calculate it and post it? That's very high. But that's the global picture. What is our picture here in Uganda? So Solomon, who is one of the oncologists at the UCI, and us, we performed a chart review of lung cancer, focusing mainly on non-small cell. Okay? And this focused from 2015 2013 to 2015, that's about 2 years, over a 2-year period. We found that 72 patients had been diagnosed with lung cancer at the UCI and met the criteria that we wanted. And as you can see, the median age was 56. And only 10% of these people were smokers. Of course, I've not yet showed you the major risk factors of lung cancer. Smoking is a major risk factor. And the most frequent histological subtype was adenocarcinoma. I think you can remember what I told you globally. If you looked at all the cancers globally, this is about around 45 to 50 globally. And you can see here we have a representation of 71%. But of course, you must note that these are clinical studies. So there may be a selection bias based on survival. We also found that up to 92% of the people had stage 4 disease, and the median survival time was about 12 months. And this paper was published in African Health Sciences by Solomon. We have also looked at what is called the Chadondo County Cancer Registry, led by Professor Wabing and others. In 2014, they published a paper looking at the change, the 10-year increase, the 10-year incidence of cancer, 1991 to 2010, and used that data to be able to reproduce this graph. So we went to calculate the percentage increase. What was the incidence in 1991 of this cancer? What was it in 2010? Okay? And you can see, this is that actually, if you just read the paper, you will not see that the highest percentage increase in cancer over that 10-year period was actually lung cancer. And we are seeing this in the clinic now because many patients are coming with the lung cancer and the others are as shown. This is reproduced data. It's not original analysis of the authors. So that's how common lung cancer is, very fatal and increasing in most parts of the world. And we will see probably why this could be the case. So what are the risk factors of lung cancer? The biggest one is tobacco smoking, and this one goes without a lot of explanation. I will not explain a lot. The second one, which is most important in our setting, is occupational and environmental factors. And which are these ones? One, exposure to biomass fuel smoke, such as wood, for cooking, for heating, for doing anything, even for roasting chicken by the roadside. And this is very common in women. And that may explain why we are seeing very few smokers among these people who have confirmed cancer in our population. There are also other exposures. These ones people know. Asbestos, which was used in roofs in most of our schools and still in some buildings to date. But the other major risk factor, it may not be very high in terms of its carcinogenicity, but because it is so prevalent, it is probably important, but we need to do studies. And this is exposure to dust particles. And this could be from unpaved roads, from construction sites, and from stone quarrying. Those particles, they irritate and they could spark of lung cancer. The third is radiation, which of course this one everyone knows. But where do you get exposed to radiation? This could be you're a health worker, you work in a hospital, or you work in other occupations which expose you to radiation. I will talk about radon. Maybe let me first leave radon. Let me go to genetic predisposition. It has also been found that people who have had a person with lung cancer are more likely to get lung cancer or any other cancer. And lung cancer increases with age, with a steep increase after the age of 40. It is also associated with other lung diseases like TB, COPD, and lung fibrosis. Now, when we come to radon, I skipped this because this is something that we don't understand what it is. So I tried to explain it. Radon is a natural occurring radioactive gas that has no odor, it has no color, it has no taste. It is produced from radium in the decay chain of uranium, and it is found in varying amounts in rocks and soils all over the world. It is believed that the highest radon is found in Norway for some reason, and the recommended exposure risk is up to 100 becquerels per cubic meter of air. So radon, which is a gas in the Earth's crust, seeps through the ground and accumulates in closed areas like homes and other buildings. It is not known to what extent people in Africa and in Uganda are exposed to radon, because we have not done studies, and this could be something that we could do. However, in areas where there is rich presence of granite, there is a high presence of radon, and in Africa, it is named in South Africa mainly, but in most of Africa, we do not know. So these are the things which could make you get lung cancer. But you know, as we know now, lung cancer has multiple risk factors, including nutrition and all these other things which cause genetic damage that we know, DNA damage, that are not yet well characterized, including waves, especially waves used in telecommunications, but there are no empirical studies. Okay, I hope I'm not taking too long. Zahara, please keep me appraised if presenters join. I have 30 minutes to finish this part. So what are the manifestations of lung cancer? How does lung cancer present? I have tried to divide this into 3 groups. There are those problems which happen if the cancer is restricted to the intrathoracic area, to the chest. There are those ones when it has gone out of the chest, but there's also a third group which we call paraneoplastic syndromes, which I will explain. So in the chest, the commonest is cough, which occurs in about 50 to 75% of the patients. It is most common in squamous cell and small cell. If I can remind you, the 4 types: small cell, which is a group of its own, squamous, adeno, large cell. The reason it is so common in squamous and small cell, because these tumors are more central, and the cough is mostly coming from obstruction of the airways and the irritation. The another one is what we call bronchoria. So bronchoria is when you produce large amounts of white sputum, but it's not like you are coughing. The sputum is just coming. And if you've been in the clinic, you've seen patients like this. So I'm not coughing, but the mucus is just coming. And this is very characteristic of adenocarcinoma. Okay? So these are a few parts. But as I will conclude, you will see these symptoms occur in almost other respiratory diseases. Now, the second one is chest pain. Up to 40% of patients have chest pain. And this is quite obvious. If a tumor grows and it touches on organs of the lung which have nerve pain receptors. I think I'll first take a break there. We learned in physiology and anatomy that actually the main lung tissue has no pain receptors. So that's why lung masses can grow very big when the patients have no symptoms. If you are lucky, if the mass starts growing towards tissues which have nerve pain receptors like the pleura, like they are central, and you get obstructive syndromes, then it is okay. But if it grows somewhere in the middle where there are no pain receptors, it will grow and become big, and then by the time it is detected very late. Pain can also come if cancer is associated with thrombosis. As I will tell you, lung cancer has a paraneoplastic syndrome which causes hypercoagulability. So if you develop clots within the pulmonary vessels, you will get chest pain. As you investigate the pulmonary embolism or clot, then we land on lung cancer. The third commonest symptom also occurs in 40%, and I will show you what we have found in our screening, is dyspnea. And of course, this occurs mainly if the cancer has intrabronchial spread, then you will get dyspnea. However, because lung masses are growing in the lung, which is 70% air, you are likely to get atelectasis. If a mass is compressing on an airway, the lung will collapse. And if it collapses, it tags onto the pleura, then you will get chest pain. Then you can get pneumothorax, or you will have pleural effusion, pericardial effusion, and then you will have dyspnea. I have put pleural effusion in red here because it has been actually one of the key presenting symptoms of lung cancer in our patients here in Uganda, surprisingly. When we started screening, we thought it was going to be mainly the huge masses, but what we are finding is that people are coming with effusion. If you just tap a little and find it is exudating, start TB treatment, you miss the point. Actually, now on our pulmonary old standard of care, you come with a large effusion, we drain it and repeat imaging. In most cases, after that, the mass will now be visible after the compressed lung has expanded. I think this one I had not seen in the textbook. We have just learned on the bedside. Those are the intrathoracic manifestations. There are other intrathoracic manifestations which I will quickly go over. They are not so big. Hemoptysis, hoarseness of the voice, when especially the Panicot's tumor, when there is obstruction of the nerves, wheezing. Wheezing, when it occurs in lung cancer, it is mainly not the wheezing of asthma and COPD, which is widespread on the chest. Here you will find a patient who has a wheeze in a particular part of an auscultate area on the lung, or I mean on the chest, meaning that the obstruction on the airways in that area alone, and now the patient wheezes only in that small area. So if you are the kind of doctor who is not following the pattern, you will miss this wheeze, and it could be the only sign of lung cancer. Panicot's tumor, which is a syndrome liked by students, is lung cancer rising in the superior sulcus of the lung, basically up here. And of course, because of its position, there will be shoulder pain, there will be Horner's syndrome, and then the hoarseness of the voice and others. I hope I'm not taking too long, but I think these symptoms are important to go through. Then we have extrathoracic manifestations. These ones will go quickly. Lung cancer can spread almost any part of the body, but the signs will depend on the organ affected. For example, in the bone, you will have pain and pathological fractures. In the adrenals, you will have issues with the electrolyte balance, blood pressure control, although this is very rare. In the brain, you will have the symptoms of a space-occupying lesion in the brain. And now we have the paraneoplastic syndromes, which I told you about. These paraneops are tumor effects that are not related to the direct invasion of the tumor, or obstruction or metastasis. There is no metastasis in that system. It is paraneoplastic. The commonest ones are things like hypercalcemia, hematological manifestations like anemia, leukocytosis, Cushing syndrome, and others as they are listed there. So as you can see, the evaluation of a lung cancer patient should be comprehensive. I think now I will be able to move faster. So how common are lung cancer symptoms? I have already given you the percentages, and I think I will just let this go. I will show you data from our patients. So therefore, what's the role of this clinical evaluation? Which is the major topic. How can clinical evaluation or good clinical acumen help us in early detection of lung cancer? We note that lung cancer symptoms overlap with many other lung cancer, other respiratory diseases. And we also note that by the time of clinical manifestations, I think as Margaret will tell you, lung cancer is advanced. And as I have explained, because if the cancer is growing in the middle somewhere and it has not touched the pleura, it has not touched the bronchus, the pain nerve endings are very few in the lung, it will just grow. And meanwhile, it will be sending metastases. However, clinically, you can suspect lung cancer if patients have persistent symptoms that are negative. I'm speaking for Africa and Uganda, for most common infections such as TB. Someone has a cough which has not gone, you've tested for TB, it is not there. Please suspect lung cancer and order for at least a chest X-ray. And should you see a nodule or a mass, refer that patient for further evaluation. This is actually what we need to do to improve early cancer detection. Everyone who has persistent symptoms, which are not TB or asthma and COPD, and is not responding to treatment, just order an X-ray. And should the radiograph or radiologist also see a nodule, a mass, ask for help. Suspect lung cancer in people with risk factors. But as I've told you, the commonest, which is smoking, is very rare here. If you take the issue of biomass, the issue of dust from roads, we are all exposed. Okay? But most importantly, always suspect and rule out lung cancer in all patients with respiratory symptoms which are persistent. I think that's the key message that I will leave here. What do we do as doctors? If something has not entered your differential diagnosis, the pre-assessment differential diagnosis, there are two as a differential diagnosis. The gut feeling when the patient has told you very little and is walking in. If you don't think lung cancer could be on the list, it will not be the things you are going to, the questions you are going to ask. You will find you have not even asked for smoking, by the way. You have jumped to pneumonia. So make sure lung cancer is on your pre-assessment differential diagnosis of a patient with persistent respiratory symptoms. And the rest will flow. As we hear from the Cancer Institute, systems have been put in place to help to do the detailed evaluation. So now, what have we seen in the 3 years we've been screening for lung cancer in this project called the Uganda, Tanzania, Cleveland HIV-associated lung cancer project? This project, like I said, started in 2019. And these are the partners. As you can see, these are the very many people. It's a U54 mechanism, so it's a very large project, which also includes awarding of fellowships. And so far we have awarded, I think, up to 10 fellowships. We will award 4 each year. And I think you can recognize many faces on this, but that's the important thing. The important thing that we need to understand the epidemiology of lung cancer in Africa and its relationship to HIV. We need to understand the driver mutations. We also need to develop AI algorithms to be able to diagnose, to differentiate lung cancer nodules from TB nodules, because that's our biggest problem in our setting. And this is our screening algorithm. When people suspect lung cancer at cancer centers, the ones who have gone to cancer center thinking they have lung cancer, we do tissue. However, we have established a network to pick up nodules and masses, like I told you, at all CT and X-ray centers across the two countries. And as you will see, we are now detecting cancer faster. What's the progress? So far, we have screened 268 patients, and we have enrolled, confirmed 114. This does not mean these are the only cancers, because each study has inclusion and exclusion. Some people don't consent, other people die before they are enrolled, but at least we have been able to screen people who look like lung cancer 268. The median age is 60. I think you remember from Dr. Chibulde's study, the median age was, I think, 56. Majority of the patients are females. This is also a key finding, because in the rest of the world, majority of lung cancer is men. You can see only 21 are smokers, 28% are smokers, okay? And then majority are adenocarcinoma. Remember, it is 67.4. This is now in the current study. If you compare to retrospective, it was 71. Here we are finding 67. And of course, stage 4 is slightly lower, 86, I think, because of active case finding. Remember there it was 92%. And then I think, let me take you to this. Oh, I wanted to show you the mortality rate. These are the outcomes that we come back. You can see the people who have died, 45.3%, very high mortality. And then I will now take you to the symptoms, because I told you I'm going to show you in these 114 patients. I think this is only Ugandan data. I think Ugandan data only. I really will comment, she's on the call. But you can see here, our main presentation is breathlessness. Then we have general tiredness, which is non-specific. You can see cough is still the commonest, 79. Breathlessness, chronic dyspnea, 57. Shortness of breath, 51. That is just terminology. And then chest pain is very common. And as I told you, most of the patients are presenting with pleural effusion. This is the histological classification. If you remember, adenocarcinoma is still the commonest, squamous, and then large cell is only 5%. Almost what I showed you earlier. And this I've already shown you. What has been our experience that people present late, of course, and then people cannot afford screening or diagnostic tests for lung cancer, CT scans, biopsies, they cannot afford. And what have we been able to do? We have been able to leverage the project to pay for the CT scans and the biopsies. But still, we need to figure out cheaper ways of detecting lung cancer. And I think that's where Dr. Okuku's presentation of liquid biopsies, biomarkers may be handy. I think I will stop there. I want to thank you very much for listening to me. Over to you, Zahara. Since I've been talking a lot, I think you can take over and moderate the session a little bit. Thank you.
Thank you so much, Professor. That has been quite an informative one. We have Dr. Mbabazi lined up. Then I think we'll be taking questions at the end of the session. Dr. Mbabazi is a research fellow at Makerere University Lung Institute and also a radiologist. Dr. Mbabazi, you're welcome.
Thank you very much, Zahara. Could you please allow me to share my screen?
Dr. Mbabazi, you can share.
Okay, thank you. Okay, so good afternoon, everyone. I'm going to discuss briefly the radiological screening of lung cancer. Dr. Mbabazi Margaret, a research fellow with the Makerere Lung Institute. Lung cancer screening in the past was done using chest X-rays or sputum cytology, but these have been found to offer no mortality benefit. And why is this? Because by the time lung cancer manifests as a nodule on a chest X-ray, most times it is already a mass at about stage 2 to 3. And adenocarcinoma, which is the common histological subtype of lung cancer, usually starts off as a ground glass nodule. Later, it may transform into a part solid nodule, but all these cannot be seen on X-ray. So through research, it has been established that high-risk patients should be screened with low-dose CT scan, and this has showed marked reduction in mortality. So what happens in the Western world is that patients who are high risk, and those are patients who are between 55 to 74 years of age, who are current or former smokers with at least 35 pack years, and within about 15 years of smoking cessation, receive annual low-dose CT scans. In a setting, we still need to determine the population at risk of developing lung cancer. And then once we have determined this population, we can establish a screening program using low-dose CT scan. But what is low-dose CT scan? Low-dose CT scan is exactly that. The amount of radiation that is delivered into the body is about 1 millisievert for males and about 1.4 millisieverts for females, which is really small when you compare to a routine chest CT scan, which delivers about 7 millisieverts for a standard diagnostic chest CT scan. So because the doses are so small, we can screen someone several times without really giving them doses that are worrisome. And then low-dose CT scan is performed without contrast media during a single maximum inspiratory breath hold. The scanning time is less than 25 seconds, and then the rest is really a matter of reconstructing the images. So this is able to detect even the smallest of nodules and also delivers very little radiation to the patient. After screening, then the findings are interpreted using the lung rads. This is the version 1.1, which is what we're using currently, and you can Google it and internalize it, or you can put it in the reading room to help you as you read the CT scans. But essentially, you're going to find two types of algorithms. There's the Fleischner guidelines, which are for incidentally detected nodules. Supposing someone came for something else and then you detect a nodule, there are guidelines for that, which are the Fleischner guidelines. But for screening programs, we tend to use this lung rads, and the scores range from 0 to 4x, from incomplete, negative to highly suspicious. And then in the fourth column of that lung rads, it gives us a hint on how to proceed. Should this patient go home, and for how long, and when should they come back for the next CT scan? Now, in our setting, we have a problem of tuberculosis and post-TB lung disease, which radiologically or radiographically mimic lung cancer. So a study done in South Africa, which is also a high TB endemic area, decided to set their nodule size to greater than 6 millimeters. So that if a patient comes for baseline low-dose CT scan screening in a highly TB endemic population, and you discover a nodule which is greater than 6 millimeters in diameter, that is considered positive. And if the nodule is non-calcified, solid or partly solid, between 6 and 10 millimeters with no malignant features, then we can repeat the low-dose CT in 6 months. If it is greater than 10 millimeters with additional malignant features, then we need to take further action and exclude lung cancer. And I think if we try to adapt this algorithm to our setting, it will help us to be able to detect lung cancer, which has been managed as TB for a long time. Now, for patients who smoke in the Western world and the other settings where they have a screening algorithm, this yearly screening continues for about 15 years after smoking cessation, or when the patient becomes too old that even if you detect lung cancer early, they would be unfit for curative management. For the Ugandan situation, we still don't know how long we would have to screen, but this is something we need to work towards. So just a few nodule characteristics that we shall see as we screen. The key aim is to define whether this nodule is benign or malignant or suspicious. And if it is suspicious, to have a plan of how to follow it up. So this is a lung window. This is a mediastinal window. And in this CT scan, we see a nodule which has a well-circumscribed margin and a small eccentric calcification. If I saw this, I would worry because of the location of the calcification. But when we look at the mediastinal window, we find that on top of the calcification within this nodule are fat components. So a nodule which is well circumscribed with a calcification and fat components is usually a hematoma, and it is a benign nodule. Now, usually adenocarcinoma starts off as a ground glass nodule, a purely ground glass nodule. Ground glass means that you are able to see the pulmonary vasculature within the nodule, through the nodule. So it's like having glass that has been fogged. So in this image where the arrow is pointing, we can see a purely ground glass nodule here. And the surrounding vessel has not been affected by the presence of this nodule. So using the lung rads, would measure the diameter of this nodule and then decide on a follow-up pattern for this nodule. But when this patient came back after 2 years for a repeat scan, within this nodule, they have developed a solid component. So already we know that this is not an innocent nodule. So by following them up, we are able to pick this lung cancer while it is still stage 1, and we can actually offer curative services for this patient. And for ground glass nodules, we keep an eye on the solid component. So in this patient, this is the size of the ground glass nodule, but within it we have these white areas, which are the solid component. Somebody's talking. Could you please mute? Okay. And then in this patient here, we have a speculated solid component within a partly within a ground glass nodule. So this one, we are almost sure that this is lung, adenocarcinoma. This is highly suspicious because of the large ground glass component and also the large solid component. So after we have seen this, then we go back to the guidelines and decide on when to follow up this patient, or when to offer surgery or when to treat. Now, this is another ground glass nodule, but after follow-up, we found that this nodule had disappeared. So sometimes you cannot just decide on the initial scan, and that's why we need an algorithm for follow-up so that we can decide what happens next. So this one, after the follow-up CT scan, it had disappeared. So this was most likely an inflammatory ground glass nodule. Now, for the solid nodules, which are purely solid, we then look at the margins, and our biggest indicator of malignancy is usually speculations from the nodule. So when we look at this nodule, yes, it is solid, but its margin has spicules coming from it. And if you're not sure about the speculation, you look at the surrounding vasculature, and you can see that it is trying to pull the adjacent bronchial and also the artery, and also the pleura is being dragged towards the nodule. So this is a highly suspicious nodule. Now, in our setting, because of TB, we are also going to meet many calcified nodules. So the pattern of calcification is also something that we need to pay attention to. For image A shows a nodule which is at the center, which has a calcification at its center to give you a sort of bull's eye appearance. And this tends to be a post-TB granuloma, which is really benign. In image B, we have a nodule which is entirely calcified. This also tends to be a benign granuloma. In image C, we have a nodule, but it has a lamellated pattern of calcification. And this one also tends to be benign. Then image D has what we call popcorn calcifications, which are characteristic of hematomas. But when you get to image E, we're seeing several eccentric punctate nodules, calcifications within an ill-defined nodule. And this is one which is suspicious, and it turned out to be a malignant carcinoid. Now, for image F, we have a calcification almost close to the one that I showed you earlier. It is eccentric, it's not within the center of the nodule. And when you look at the margins of the nodule, there are some speculations along the margins. So this would actually be a calcification within a malignant nodule. So because of TB, we need to really pay attention to the pattern of calcifications that we see. And that, coupled with the margin and the size of the nodule, can help us to decide whether it is malignant, benign, or just highly suspicious. Thank you.
Thank you so much, Dr. Mbabazi. Maybe to our speakers, we have a variety of people online. We have the scientists, and we have those with a completely no medical background. So I continue to urge you to keep some of those terminologies down so that we are on the same page with all the participants on board. I don't know if we have Dr. Okuku online. Dr. Okuku will be walking us through the biomarkers of lung cancer. Then after his presentation, we'll have Dr. Nixon representing the Uganda Cancer Institute Executive Director, Dr. Jackson Arem, and we'll have questions. Please just keep those questions coming in. We'll have them answered at the end of the last presentation. You're welcome, Dr. Fred Okuku.
Allow me to share my slides. let's see. If not, I can send them to you so you can share them. And I just send me your email. So,
Dr. Okuku, you can actually share them directly.
no, my computer seems to be giving me a little bit of challenges. So I will send them. Could you share your email so I can send them directly to you?
Okay, in the meantime, we can have at least, I think, 2 to 3 questions as we work on Dr. Okuku's presentation. You unmute and share your question to either Professor Kirenga or Dr. Mbabazi. If you're not asking a question, please unmute yourself. Let's have those questions coming in as Dr. Okuku shares his slides.
Thank you very much for that wonderful presentation. My concern is what could be the contributing factor for the high incidence of CA lung in females compared to male in our setting here, Uganda.
Okay, can you have like 2, 3? Then we answer at once. We have noted that one from Sebastian. Okay, maybe I will pick them from the chat.
My second question is, how effective is the cytology on the pleural fluid when we are suspecting CA of the lung?
Good afternoon. Yes, I see Zahara had she has gone off. Joanne, you could please unmute and ask your question.
Thank you very much, Irene. I have 2 questions. So one question which I posted in the chat, and I'll just ask it, is about is there, I've seen some information saying that there is a risk of smokers actually increasing their risk of getting lung cancer from the imaging of CT. I would like for Dr. Margaret to comment on this, and then in light of the recommendation to screen them annually, how does it improve, how is it beneficial to them, given that information beforehand. Then the other is we've had Prof. Kirenga talking about the chest X-ray for lung cancer screening, and Dr. Margaret recommending low-dose CT, especially now that we are speaking of early diagnosis. Is there a role for the chest X-ray? And then also to just enlighten us on the availability of the low-dose CT in Uganda. Thank you.
Thank you so much, Joanne. Dr. Margaret can respond to those questions as the other members join again.
Okay, thank you, Joanne, for your question. The first one was about the role of screening among smokers. If we look at the international guidelines, they tend to offer screening CT to those who are above between 55 to 74 years. Like we had from Professor's presentation, the median age of the lung cancer sufferer is at least above 50 years. And perform unnecessary surgery on benign nodules. So we keep an eye on the nodules, but somebody should be within an age where they are at risk of developing lung cancer. So we probably need to set a threshold age in our setting, but also the amount, the pack years of smoking matter when you're trying to categorize the risk. There is low risk, medium risk, and high risk. And so from the patients, we will take the patient and then we are going to categorize their risk, and then we are going to set a screening protocol or program for them. But the best would really be smoking cessation, because we know that once they stop smoking, then the risk does reduces markedly. But if they smoked for a long time, we are going to continue screening them for at least 15 years after smoking cessation to make sure that we catch the cancer when it does come. The second question was, is low-dose CT available? We're all aware that the government has installed CT scanners in all regional referral hospitals in Uganda. That plus the CT scanners in the private sector is enough for people to actually access CT scan services. Now, the low-dose CT is just a protocol that you set within the CT scan. So it can be done on any CT scanner. We just set the protocol that this patient will have just a low-dose CT scanner. Then the doses of radiation will be adjusted accordingly. The role of chest X-ray, I will not say that it doesn't have a role, but if we are aiming at catching lung cancer early, a chest X-ray is unable to pick nodules when they are still small, and yet that is our goal. So if we catch them when they are already masses, then we may not really get the net benefit of catching lung cancer early. But yes, it still has a role in picking lung nodules, but for purposes of screening, by the time you see a nodule on a chest X-ray, the lung cancer has grown. So that is still something that we need to think about. We have more X-rays than CT scans, but for purposes of screening, a chest X-ray is unhelpful. Thank you.
Okay, thank you so much for those questions. We shall take more questions, but we can have Dr. Okuku, a senior medical oncologist at the Lung Institute. Dr. Okuku, you're welcome.
Thank you very much. Can we go to the next slide, please?
Let me just share again.
Next slide. So as they move the slide, maybe I should start by
Yeah.
okay. Let me start with just a little background of how we approach diagnosis of lung cancer. So as Professor Bruce has already introduced issues of symptoms. Once you have those symptoms, you see a doctor, and once a doctor has noted the mass in the lung, they will take a tissue biopsy. And that tissue biopsy will be analyzed by the doctors. And this is what might come out of the tissue biopsy on histopathology. So histopathology is an analysis done by a specialist doctor called a pathologist. He looks at the tissue and tries to make out what type of lung cancer. Now, there are many types of lung cancer, and the commonest we see in Uganda is an adenocarcinoma. As you can see, that which I'm pointing towards there, that is the blue color there, 52%. Another patient may have what we refer to as squamous cell, and sometimes we may have other non-small cell. This NC stands for non-small cell lung cancer. That's about 11%. But you may also have people with large cell lung cancer. So this description is on histopathology. So when you look at it further, the non-small cell are the commonest. Majority are non-small cell. The small cell, what we see in smokers, people who smoke, get the lung cancer type called the small cell type. Next slide. Next slide, please. Okay, as I get to the next slide, so this is what we analyze, and then after that analysis, we then will move on to your treatment. But that is not all. We will now move to what we are referring to as biomarkers. As you're aware, there have been many changes, and diagnosis of cancer generally has improved, and we can now be able to see much more than what you see on the ordinary microscope. So the tissue that I've described here can be taken further, and we do a molecular diagnosis, or what we refer to as immunoprofiling of the tumor. So there are other markers that you may not see on the microscope, and immunoprofiling does help us to be able to bring out details about a particular tumor. So this slide, we would like to show you the commonest biomarkers in these tumors, the non-small cell lung cancer. And as you can see, the small cell squamous cell carcinoma has a lot of biomarkers, as you can see. The commonest here is the EGFR, which stands for epidermal growth factor receptor. That is the commonest biomarker in non-small cell. It also happens in adenocarcinomas, and as you can see, we have a significant portion of patients with adenocarcinoma of the lung expressing the EGFR. However, they also do express other markers. You can see the KRAS These are all mutations that have been found in many of these patients with cancer of the lung. So when you have been diagnosed, this is a further analysis that is done on the tissue. Unfortunately, many of these tests are not easily available in country. Some of them are, and at UCI, we do have the capability to run these tests. The platform is available. I know that the lung study that we are running right now also has the capability to run many of these tests. Next slide. So those tests that I have described, these mutations, are a requirement. So we need to check your tumor. We need to check the patient's tumor for all these biomarkers that are listed here. However, it's not practical. As you can see, there are a myriad of biomarkers, and these are very expensive. So we tend to go by the commonest. As you have seen, EGFR is common, LK is common, KRAS is common. The other EGFR biomarkers that are also common. As you can see, the list is over here. EGFR other is 2%, KRAS is 25%. So going by this, we try to, because it's not practical to run all this, so we normally run 3 main ones. So a typical patient will have, number 1 will be the epidermal growth factor receptor mutation. As you can see, the very first one there. We will also have the KRAS mutation, the LK, and LK stands for anaplastic lymphoma kinase mutation. And then we usually also run the ROS1. These are quite common. They have targets in terms of drugs to target those. So most of those which we run have targets. So in other places, we would have mapped out our population already, and we would know by now what are the commonest mutations in our population. My clinical practice and experience tells me that EGFR is quite common. The lung cancer patients who receive who are close to 800, probably 50% of them will be expressing the EGFR, and that's how it is world over. Next slide. So those mutations are called driver mutations, and those are the ones that cause the cancer to grow. And so clinical application of that is that once you find the biomarker expressed in the tumor, then you need to target that biomarker using a target. And those drugs are targeted therapy drugs that are available. And these are some of the examples targeting particular mutations: epidermal growth factor receptor inhibitors. The commonest here is erlotinib. We have gefitinib, which was the first, these are first generation. We have osimertinib, which is a second generation drug. We have a lymphoma kinase inhibitor and ROS1. These 2 mutations are very similar. They're like brother and sister, and so the same drugs work for both of them. Crizotinib, alcatinib, and brigatinib, all these are available. We can easily get them for our patients. There are some very rare mutations or biomarkers for these particular inhibitors, like MET inhibitor. Crizotinib, again, is one of those drugs that we use for the anaplastic lymphoma kinase mutation, but it can also be employed in when we have MET mutations expressed in tumors. Some lung tumors also express a very similar mutation that is driver mutation that we see in breast cancer. That is the human epidermal receptor 2. The drug of choice here is trastuzumab, afatinib. These are all available in UCI. We do give trastuzumab free of charge to most of our patients. We have RET inhibitors, cabazitaxel, we have BRAF inhibitors. Next slide. We have MEK inhibitors. We have the NTRK1 inhibitors. We have the PIK3CA inhibitors, and the PDL1. These are checkpoint inhibitors. I will speak a little more about these, but some of the drugs we use here are atezolizumab and pembrolizumab, which is one of the commonest immunotherapies. So the PDL1 biomarker is one of those biomarkers that we do on lung cancers because it's expressed on some lung cancer tumors, and we do have druggable. This is a druggable driver mutation because we have drugs that are available to block that driver mutation. Next slide. In this slide, I want to show you FDA-approved targeted therapies. You need to have an eye of faith to be able to read through this, but it's a crowded slide, but it's just what I have already highlighted in my previous slide. Drugs like osimertinib, we have afatinib, erlotinib, and many others. Next slide. These are further mutations. Some of these have been approved and some of them are in the pipeline. They are yet to be approved by the biggest authority in terms of drug approval is the FDA, and many of these researchers will first get approval from the FDA before the drugs can therefore be distributed all over the world. Next slide. And this slide, I want to show you the different immunotherapies that are available for treatment of lung cancer and when they were approved. Atezolizumab in 2020, pembrolizumab 2016. There are others that were approved with combination with chemotherapy, like pembrolizumab and paclitaxel or nab-paclitaxel. This was 2018. Next slide. Right. Before I conclude, this is one of my last slides. I should hint a little bit about liquid biopsy. Sometimes we have very sick patients, elderly patients, where we cannot do tissue diagnosis. We can take a tissue. And the liquid biopsy is one of those that we can employ on a variety of cancer biomarkers. And some of the biomarkers here that are picked up on the liquid biopsy include circulating DNA, abbreviated as ctDNA, the microRNA, and circulating tumor cells. So when you have a cancer going on in your body, what can happen is the cancer keeps breaking off and going into the blood circulation. And so doctors can utilize that, take up the blood sample. They can also take plasma, they can take urine and figure out what is going on. And in lung cancer, this is one thing we can apply. We can apply a liquid biopsy to help us make some, infer to what might be happening. So patients who are medically unfit, instead of going through a very difficult invasive biopsy, intrathoracic or percutaneous biopsy, a liquid biopsy is one that can actually be employed. We could also employ this as a response marker to see how you're responding to treatment. I think this should be my last slide. Thank you very much.
Thank you so much, Dr. Okuku, for that insight about the treatment and also the biomarkers. Yes, Dr. Nixon, you're welcome to give your presentation. Dr. Nixon is the head of training at the Uganda Cancer Institute.
Thank you, Irene. Mine is going to be a very brief presentation, really looking at what the Uganda Cancer Institute is doing to address this rising incidence of lung cancer in the country. As Professor Kirenga has mentioned, it's been one of the fastest growing cancers in this country. And I've outlined some of the things that the Cancer Institute has done and is doing to address this growing challenge of cancer. The first, of course, is we have developed a national cancer control plan. And the National Cancer Control Plan really outlines what each stakeholder does or is supposed to do in the cancer ecosystem. So what the private sector is doing or needs to do, what the Ministry of Health is doing, what the politicians need to do. And we're hoping that this National Cancer Control Plan is going to be launched later this year. And why we need the Cancer Control Plan really is to address the shortfalls that we are having of addressing cancer as a whole. And once we launch it, everybody will have a role to play or will realize their role in controlling cancer in the entire country. In addition, both Bruce and Dr. Okuku have talked about early detection, and Cancer Institute has a fully fledged outreach and prevention department who go out to the community to sensitize the population. And now when they go out to sensitize the population, of course, they are not doing early detection in the community, but we hope that when they sensitize the population, people will come early. And Margaret has talked about the diagnostics, but for early detection, but also the Cancer Institute is improving diagnostics, and they have about 2 slides talking about the laboratory capacity and then the imaging services. Most of our lung cancers are diagnosed through imaging, and then of course followed by the lab. We're also expanding access to cancer treatment. Dr. Okuku has talked about these targeted therapies. These FDA-approved therapies are not yet available here. Some of the latest therapies, crizotinib and the like, are not yet available here, but we're also expanding access to these services. Professor Kirenga talked about cancer registration, how almost all the data we have is from the Chadondo County. I will show later that we want to expand cancer registration services to cover a larger proportion of the population. And then we're also, of course, expanding human resource capacity. Professor Kirenga has talked about training and the fellowships. We have regional cancer centers. And of course, we're also strengthening research, as Fred has talked about, Okuku has talked about. Now, I will walk through these slides very quickly because we are behind time, but this is some of the laboratory diagnostic capacity that Dr. Okuku has talked about. We're actually able to do a lot of the molecular profiling that Okuku has talked about. So we have a fully fledged pathology laboratory. We're able to do the clinical pathology, coagulation, flow cytometry. All these we're able to do at the Cancer Institute. Of course, of interest is immunohistochemistry, which we're providing to all patients. And EGFR is one of the components that we do for lung cancer. So we're able to do it here at the Cancer Institute. And when it comes to molecular, we have capacity for PCR and sequencing. We have ability to do EGFR, KRAS, BRAF, the V600E mutation that Dr. Okuku talked about, PIK3CA, we're able to do HER2, we're able to do BRCA1 and 2, and a number of others that are important. But importantly, we're also able to do biobanking. So we have tissues that if anybody wants to do research in the future, we'll have these tissues. Professor Kirenga and Okuku are talking about how we need to be able to describe the molecular profile of our cancers here. And this biobank is going to be a resource for people who want to do this kind of science in the future. So we'll be able to map the population. Regarding imaging, we're setting up a comprehensive imaging unit. And these are some of the services that we have. But for lung cancer specifically, we have a CT scan, which is fully functional. Of course, the X-rays and ultrasound are there, but importantly, we have the CT scan. We are not using the low-dose CT scan for screening as a country yet, and maybe that's something that Professor Kirenga and Okuku, something that you need to take up, screening guidelines for Uganda. Whether this would be affordable, accessible is a different issue, but at least some of the services are available here at the Cancer Institute, and they're also available at our regional cancer centers. And as you're aware, these services are also available at the regional referral or the regional referral hospitals. We also expand infrastructure for care. This is some of the infrastructure. I will not emphasize this. And this is sort of the future infrastructure for Cancer Institute. And these are some of the services that we hope to have, including a cancer research and innovation campus that is going to support the molecular component. We have radiotherapy facilities, which we have 3 Linux, 2 Cobalt 60, and in total about 8 radiotherapy machines. Importantly, we are training personnel for radiotherapy. Dr. Chibude, who Bruce talked about, is one of our radiation oncologists and is also directing our fellowship training program to really equip our staff with capacity to handle this. Importantly, as the Cancer Institute is, of course, decentralization of cancer care, a majority of the patients, actually only 20% of all new cancer cases in the country make it the Uganda Cancer Institute. And we think that distance is one factor why patients don't come to the Cancer Institute. And so what we have decided is to actually develop regional cancer centers across the country. And our plan is that the Uganda Cancer Institute at Mulago is going to be our center of excellence for cancer care, and is going to be linked to these 4 regional cancer centers: the Western Uganda Regional Cancer Center, commonly called the Mbara Cancer Center, serving the Western region. We have the Northern Uganda, Eastern Uganda, and the West Nile Cancer Center. And we expect that patients will be going much earlier to these centers. The Gulu Cancer Center is open as of this month. It has CT scan, it has MRI, X-ray, and sorry, not MRI, X-ray, CT scan, and other imaging modalities, as well as a lab that can actually pick up these cancers early. And we hope to have the same facilities in all these regional centers, as well as the treatment facilities. And any complications, the patients can be referred to Mulago. But the goal is also that these centers are going to be working with the regional referrals and the universities in those regions to do outreach and education in the community, hoping to catch patients early. And in addition, this is the picture of the Gulu Cancer Center. Phase 1 is complete. Phase 1 are the smaller buildings this side. But in addition, all those regional cancer centers are going to be linked to population cancer registries. And our goal is to expand the coverage of the registries from the current about 12% of the Chadondo Cancer Registry to 35% of the population. So our Arua Cancer Center will be linked with an Arua Cancer Registry. We'll have a Gulu Cancer Registry. There's currently a small Gulu Cancer Registry that we want to strengthen, and also link it to the regional cancer center there. Then we'll have one in Western Uganda. We'll have one in Eastern Uganda. And then, of course, there will be the Kampala Cancer Registry or the Chadondo Cancer Registry. And we think that all these registries will feed into a national cancer registry. And this national cancer registry, we expect to give more representative information on the risk factors, the cancer risk factors, not just lung cancer, but all cancers, but also more information on the epidemiology and the trends countrywide. And we're also strengthening research. Dr. Okuku talked about this. We need to be able to understand the biology of the cancers, the epidemiology, and we're building a fully fledged facility that, among other things, will contain reference laboratories as well as research space where researchers can sit and conduct research. And of course, we're still doing outreach. And I will stop here for any questions. Thank you.
Yes, thank you so much, Dr. Nixon, for really enlightening this. We are happy that we are decentralizing the treatment of cancer. I think it will be very, very helpful to the patients. Yeah, but maybe I'm wondering when they will become functional. At least in Mbara Cancer Center is fully functional. So I don't know when the rest will also become functional. Maybe you'll comment on that later. Let me give chance to other members to ask questions. Please unmute and ask questions to any of the presenters. Then later we shall go to the chat. Any questions?
I think, Irene, I can start by answering the ones from the last session.
Yeah.
And I see there are several questions, of course, in the chat. Maybe since you are helping us to check there, you can see which ones we can answer in the remaining time. So one question which was voiced by Sebastian was why are we seeing a lot of lung cancer in females, of course, without a lot of smoking? We think it is their high exposure to smoke, indoor air pollution from smoke, which could be causing this as a unique factor. As we know, women are more exposed. This is what we think now. Then someone had talked about the chest X-ray. I think Margaret answered this very well. However, we must distinguish between screening and early detection. In patients who are already seeking care, already with the symptoms, there is something growing in the lungs. So you could easily pick it with an X-ray, but we appreciate that we need to make CT scans more available. So if you combine the X-ray and the clinical assessment, you should be able to suspect lung cancer and order for more investigations. So those were from the last session. I think I will stop there. Margaret didn't answer. This one is a good one. People thinking that the CT scan itself will expose you to radiation and you get lung cancer in the process of screening for it. Margaret, why don't you dispel this misconception?
Thank you very much, Prof. The effects of radiation on the body are two. You have the stochastic effects, which it's just chance. When radiation goes through the body, it causes some changes within the chromosomes, and in the recombination, things can recombine wrong. That is just chance. It can happen to you while you walk in the sun, because you receive more radiation from walking in the sun than from a low-dose CT. But also there are deterministic effects which come from receiving a lot of radiation. And that's why I labored to give you the doses of radiation that you receive during a screening low-dose CT scan. You only get 1 millisievert. And yet, if you come to do a normal routine chest CT scan for other things, you're going to get about 7 millisieverts. So yes, I cannot say that you cannot get the stochastic effects, because that is just chance. But in terms of deterministic effects, the doses are so small that really you're not going to have. Hello, sorry, I forgot to unmute. Sorry. That the effects of radiation on the body are two. They are stochastic, and then they are deterministic. Stochastic effects occur by chance. It means that if you walk in the sun, you might get something. You have a lot of radiation coming from the sun. And the effects, the radiation that you get from the sun is even more than what you get from a low-dose CT scan. That's why I labor to give you the doses. You get 1 millisievert from a screening CT scan. And when you walk into the radiology department to get a routine CT scan, you get 7 millisieverts. So the chances of getting effects from this radiation Yes, the ones of chance happen and we can't really determine who, but the doses are so small that really the risk is negligible. Then the deterministic effects come from high doses of radiation, which we do not experience in diagnostics. We only get those very high doses during therapy, when you're treating something and trying to burn it with radiation. So in terms of radiology, just checking up, the doses that we give are very small. The chances of them affecting the body are not zero, but they are negligible. Thank you.
Yeah, thank you so much. We have some more questions from the chat. This is from Vicky, who is asking if persistent GERD is a risk to getting lung cancer, and also if HPV infection is also a risk for lung cancer. The other question is about the effectiveness. How effective is cytology on pleural fluid, especially blood stained? I think you're asking how effective in getting a diagnosis when you're using pleural fluid. And the other question, okay, Dr. John's question has already been answered. We have some other questions. Someone saying, thank you, Dr. Kirenga. I think this is about the risk, why women are more at risk. I think that has been answered. Then there is a comment on the role of cervical lymph node biopsy in the diagnosis of any of the types of lung cancer. Refer guidance for suspected lung cancer patients outside the Kampala region. So I think the first two questions can go to Prof. Kirenga, then this other question can go to Dr. Okuku. Prof, you can take on the first two questions.
That was HPV and the persistent GERD.
Yes.
Of course, many viruses are oncogenic, but we don't have enough data that HPV is an oncogene for lung cancer. Maybe Freddie will comment on that, and Nixon. Then the one of GERD causes airway irritation, causing obstruction, also no clear link with lung cancer per se. But we know the seepage of gastric acid and regurgitation of acid to the esophagus can seep into the trachea and large bronchioles and cause an asthma-like syndrome. But whether that may eventually cause lung cancer, the data is not available. Thank you.
Thank you. Prof, the other question was about if someone can use pleural fluid for cytology, how effective would it?
This is a pathology question. I can't authoritatively answer it. I can only tell you from what I have seen as a clinician, is that if you take large amounts of pleural fluid, you can see malignant cells in them, but also you need to think through the pathophysiology of the effusion. Some effusion in lung cancer is due to obstruction. Others are due to inflammation, which is remote from the tumor. But other effusion are due to direct spread of the tumor into the pleural space. The latter, you can easily catch the malignant effusion. In the first two, actually, may only get an inflammatory picture without malignant cells. And that's why you see, even when the pleural cytology is negative, if we drain the effusion and see a focal mass in the expanded lung and the biopsy, you find it is cancer. over. But we miss having the pathologist here to give more information.
So, Bruce, I just wanted to comment on just one aspect of HPV and lung cancer. So there's no evidence that HPV causes lung cancer. There have been a few studies that have been published that have found HPV 16 and 18 in some lung tumors and tissues, but there's no causative link between lung cancer and HPV, although of course it's still an area that's open for investigation, but currently there's no causative link. And then regarding cytology, the answer is, like you rightly said, it's a yes and no answer. That when you get the profusion, you'll be able to find malignant cells, but it's unlikely you'll be able to make a conclusive diagnosis from the profluid. You can do other ancillary studies on the profluid, but usually after the profluid, somebody will ask for a biopsy, or they can do genomic studies on blood, like Fred was saying, to make the conclusive diagnosis.
Thank you.
Thank you, Dr. Nixon. You're the best person for this other question. We've just talked about HPV, and there's a question here about the role of cervical lymph node biopsy in the diagnosis of any type of lung cancer. And also you could talk about the referral, guide on referral for suspected cancer patients who are outside Kampala.
So we'll start with the last one of suspected referral. Suspected referral patients can be directly referred to the Cancer Institute. Unlike in the past, we no longer require histologic diagnosis to admit patients to the Uganda Cancer Institute. So suspicion is enough, and we do the investigation here within Cancer Institute and Mulago Hospital Complex to establish the diagnosis. If it's not cancer, the patient is referred to the appropriate care unit to manage. And of course, somebody has just posted that if somebody deteriorates from the community, the answer is yes. If you deteriorate from the community, as a rule, you go to the nearest health facility for first aid to be stabilized before referral to the Cancer Institute or to another tertiary care facility. Regarding cervical lymph nodes, it is not best practice to make a diagnosis on cervical lymph nodes. You'll find malignant cells or invasion or effacement of the nodes, and usually you have to actually find the primary where the metastasis is coming from. Remember, there are very many cancers that metastasize to the cervical lymph nodes, including breast cancer. And also breast cancer, so of course, if it has gone to the lungs, also cause the proeffusion. So usually you have to get the primary as well.
Okay, thank you. We have some other question about the median age for women, if it is different from that for men, given that women have a higher incidence. Then we have a comment here or concern from Mr. Semper asking, they have a kid who has a persistent cough for close to 2 months, tried several mild hospitals and Mengo, but no results. It is deep cough and a deep voice. Maybe Prof. Kirenga will respond to that. And we have something about management. I think Dr. Okuku will be the best person to respond to this. Is it possible for patients who have mixed mutations? How does that impact management? Yeah, so she's asking, is it possible for patients to have mixed mutations, and how are those managed? And yes, we also have Dr. Frank Mugabe. Yes, you're very much welcome from MOH. He's asking, what can we do to prevent lung cancer? And what are the chances to get a cure or total eradication of lung cancer? How can lung cancer be detected easiest, and what are the survival chances? We can start with Dr. Okuku.
So mixed mutation, that's a good question. From the biomarkers that we talked about, you could have more than one, although it's not common, but you can have more than one biomarker positive in a particular lung cancer tumor. You can also have an EGFR positive tumor as well as a PDL1. PDL1, that's for the immune checkpoint inhibitors. So you can have both. And so how do we go about that? So if you have more than one or a mixed mutation in a tumor, we tend to look for which of the mutations is druggable or has an approved drug. That's number one. Number two, is it significant? There are further tests that can be done to see whether the mutation is significant. It's only those that are significant that are taken. You can have an EGFR mutation, but it's from another loci, which is not druggable, which is not significant, and that will not be helpful. You only look for those which are druggable or those that are significant at particular loci of the gene. Now, when you have an EGFR positive tumor, as well as PDL1, what's the recommendation? The recommendations recommend that when you have both EGFR and PDL1 positive tumors, you treat the EGFR tumor. The immune checkpoint inhibitors are not as responsive in a tumor that is EGFR positive or a tumor that may be ALK positive. So you treat the mutation that is positive and then leave out the immune checkpoint inhibitors for that matter. Chemotherapy can also be combined with the immune checkpoint inhibitors, but we do not commonly combine chemotherapy with the targeted therapies. So that's how we handle those mixed mutation tumors. Thank you.
So Fred, just to add one small thing is that almost all cancers have multiple mutations, but like Dr. Okuku has said, not all mutations are clinically relevant or have drugs, but almost every cancer will have multiple mutations. Many times, the more mutations you have, the more likely the cancer is to escape treatment, so to become resistant. So it's similar to what you'd have in HIV. And cancer is basically, you have lots of mutations, and some cells are sensitive to some drugs, and some cells are not sensitive. That's why you have combination chemotherapy in cancer, similar to combination antiretroviral therapy, because you're targeting cells with different susceptibilities.
Okay, thank you so much, Dr. Nixon, for that addition.
Thank you.
Maybe you could also summarize something about Dr. Frank Mugabe's question about the chances of getting a cure, auto-eradication, and also how we can easily earliest detect lung cancer and what are the survival chances?
So is that for me or for Dr. Okuku? I can answer the last component about eradication of lung cancer, and the short answer is no. One, it's multifactorial. It's difficult to eradicate a disease that has multiple risk factors. For cervical cancer, it's relatively easy because you can vaccinate against HPV and you will have prevented it. Like Dr. Kirenga presented, there are multiple reasons why people develop lung cancer. So you have to eliminate all these risk factors in the community, which is as you industrialize more, as the air gets more polluted, as you have all these other risk factors, the short answer is no. We're not going to be able to eradicate lung cancer, but we're going to be able to maybe in the future screen early, detect early, and treat our patients. so that we can improve survival from lung cancer. Fred, maybe you can take down of treatment.
Yeah, cure for cancer generally is far off. There are many scientists who are trying to approach this in many ways. One of it is by looking at the genes responsible for aging, and you know, sort of using gene therapy to edit those genes. The other approach that scientists are using is to look at some of the commonest genes that are associated with particular cancers. But this is generally far-fetched. I mean, it's far off, impossible to cure, get a cure or to totally eradicate cancer. So difficult. Why? Because as Nixon has said, if you have a particular habit that will expose you to cancer, that will definitely come with time. If it is smoking, if you continue to smoke, the cancer will come. How can we eliminate? Unless you stop smoking. That's probably the best way to prevent it. So prevention is better than cure, as the going says. Cure is not something we can achieve. It's difficult. Thank you.
Okay, thank you so much. I see we still have a few minutes. We are going to give Dr. Nixon a chance to finish his questions. Then Prof. Kirenga will also attempt his last set of questions. Dr. Nixon, there is a question about how much cancer or lung cancer awareness has been created across the country to boost early detection. And I also have a question. It was about without cancer control plan, how has it been impacting on the institute treating better, and which difference will it create?
So, thank you. The first question on the lack of a national cancer control plan, the answer is it's not that we haven't been doing anything. We have been doing a lot of work, but what the National Cancer Control Plan does is it makes sure that everybody is involved in this cancer fight. It's a multi-sectoral or government-wide involvement or engagement, that every part of government is involved in cancer control. So you have agriculture that's involved in the pesticides, NDA. You have the local community, you have the, so it's basically defining the role of everyone rather than delegating the entire cancer fight to Cancer Institute. So it's really about putting everybody at the forefront of fighting cancer. Regarding outreach, the countrywide cancer dissemination or awareness is estimated at about 14%. That the people who know about cancer and know what to do is about 14%, meaning that we have a lot more to do, and many more people don't know what to do when they have certain symptoms or what these symptoms mean. Thank you.
Yeah, thank you. Maybe before we go to Prof, I would also want to ask Dr. Okuku. Most of our patients who diagnose or who go through a lung institute and then we send them to CI for treatment, most of them are on erlotinib. So I would like to know, and I see from your presentation, it works better for patients who have EGFR. And most of these patients are started on that treatment before even the mutation analysis is done. So are we treating patients based on the druggable mutations, or maybe which drugs are available?
Oh, thank you, Irene. I mentioned in my presentation that the commonest mutation in adenocarcinomas is EGFR driver mutation. That's the commonest that we see. Now, as you realize, many of the patients cannot do any of the biomarkers I have mentioned. It's because of the cost. So what we sometimes do clinically, when we get these patients, we give them a trial for about 2 weeks as we wait for particular tests to be done. And during that trial, we monitor them for response. We know that for these targeted therapies, the response is pretty drastic. Many patients who are EGFR positive, once they are exposed to the EGFR mutation inhibitors, they respond drastically. If they have an infusion, it will disappear, their cough will disappear. So we use those clinical symptoms to help us as we navigate this very difficult journey for our patients who anyhow come very late. And many of them, when they come late, they are not even fit to go on chemotherapy, as you know, because of, various complications of the disease, weight loss, poor feeding, respiratory distress, and so on and so forth. So we do a trial as we wait, and because many of them can't even check any of the biomarkers. And once they do respond, then we use that as a marker for continuity for treatment. If they do not respond, we usually will switch them to chemotherapy, and quite a number of them who fail end up on chemotherapy. So we use that based on the knowledge that we know that the commonest mutation is EGFR, 50 to 60%. And the space is lacking. We hope that through this lung cancer study, we will be able to know how many of what population of our lung cancer patients are EGFR positive. So it's a research question.
Okay, thank you so much. Just remind me, those who are interested to register for the CPD points. In the next few minutes, I'll request Professor Kirenga to summarize, then we can close the session.
I'll try to summarize because we have very little time. The misconception about the prevalence of smoking in our lung cancer patients and whether smoking is a risk factor. Smoking remains the biggest risk factor. Of course, you can imagine if this prevalence increased, we would even be having an epidemic of lung cancer. The other risk factors are now driving it, but we would not want smoking to jump into this queue. That question is also related to vaping. Vaping is a new way of consuming nicotine. The available data is still limited, but with the little that is there, shows that vaping can cause lung cancer and other nicotine-related problems. There was a question on the child with the persistent cough. I'm not a pediatrician, as you all know, but what I know is lung cancer is very rare in children. This persistent cough is most likely an airway problem, and our pediatrician can help this person to evaluate. The cost of tests in the screening project, we have several waiving mechanisms. The first one, we ask the hospital, lab hospital, to waive. Then next step, we may come in to pay for the biopsy, which is also expensive. But we encourage patients to pay for the tests, but when they fail, we can pay for the tests and also the imaging, but there is a system. I think there was a question, very, very interesting epidemiological question. Since radon is known to come from underground there in the rocks, I think my friend Ronald Galiwango, commonly called Galix, has raised this. With the increasing behavior of digging this underground water, how much radon contamination we have in our water systems, even in the natural occurring wells. So all these are gray areas, and it concludes by saying probably we need to go and do these surveys. So maybe one fellow in MLI will pick this up and we'll see how we can do a survey of radon in homes where there could be a high risk. I have seen many comments, but probably the communication department will put them up. We can answer them as we go along on the YouTube channel. I think I will give my concluding remarks because I may not come back. Thank you very much for joining this discussion. I thank my co-presenters for a good job well done. That will be all from me, Irene.
Okay, once again, thank you so much. Yes, I see someone has raised their hand. Oh, no, they are saying thank you. Okay, yeah, thank you so much, the presenters. Thank you so much, Lung Institute, Uganda Cancer Institute. And thank you, Zahar, and also the communication team for really putting this up. Yes, I would like to thank everyone who has attended and wish you a good evening. Thank you so much.
Irene.
I do.